All right, so welcome everyone to this webinar, which is part of the Artificial Intelligence Seminar Series at UQ, which is part of the UQ AI Collaboratory. This is the third talk in our series, and today we have a special guest with us, Professor Paul Hodges from the School of Health and Rehabilitation Sciences. Different from other talks in this series, Paul's talk is not necessarily about AI per se, but rather on personalized approaches on back pain and the potential applications of AI. We hope that this creates a conversation between computer scientists, engineers, neuroscientists, and clinicians, which is the big goal for our UQ AI Collaborative Initiative. It is my pleasure to introduce Professor Paul Hodges, who is, as they would say here in Australia, an absolute legend. He has a doctorate in rehabilitation and neuroscience, and is a fellow of the Australian Academy of Science. Paul's research has unlocked new ways of understanding pain, how it relates to how we move, and its rehabilitations. And he uses a diverse approaches to research, from studies of single cells to humans, clinical trials, and translations into practice. For his work, Paul has won the Premier International Prize for Back Pain 5 times. He has authored more than 500 peer-reviewed papers, and his research has been cited more than 52,000 times. He has received more than $52 million in research fundings to undertake his work. Paul, welcome. We're very looking forward to this talk, and yeah, you can start whenever you want.
Sure. Well, thank you very much, Alejandro, for the invitation and for the introduction. And as you've alluded to, what I'd really like to do is to paint a picture of where we think artificial intelligence may have a role in helping us solve the problem of back pain. And what I want to do, just first of all, is to give a little bit of a picture of how bad that problem is and why there is such a problem. I want to talk a little bit about the work that we have done to understand the condition, and then I want to have some discussion of where I think treatment could go and why I don't think we'll be successful unless we can take advantage of the advances that there are in artificial intelligence. So I want to talk a little bit about where I think that might fit in and how the expertise of people involved in this initiative may be able to help us to overcome those problems that I'm going to talk about. So the talk is about musculoskeletal pain, but I'm going to use low back pain as the exemplar of a musculoskeletal pain condition. And the reason for that is that back pain is the leading cause of disability in the world. It is it's associated with substantial morbidity that is greater than cardiovascular and diabetes and other conditions which we commonly think of as the major health complaints of our society. But in fact, back pain is right up there, and it is a major problem. It affects many people in our society. In fact, 80 to 90% of people have back pain at least once in their life. And at any point in time, about 18% of the population are being troubled by back pain. And within a month, 30% of the population has some trouble with low back pain. It affects men and women of all ages. And the tragedy is that when we look at the burden of disease data that are from 10 years ago until now, the outcomes and the prospect for people with pain is actually worse rather than better. And that's despite enormous investment of money in research and healthcare. So one of the biggest problems is that even the best treatments have really modest effects. And so there's many different trials. In fact, just a few weeks ago, there was a new systematic review published in a Cochrane collaboration systematic review investigating exercise management for low back pain. There are 290 randomized controlled clinical trials costing millions and millions of dollars that suggest that exercise is better than doing nothing, but you really can't make any decisions about when you would use it versus something else. And it's no more effective than any other treatment when it's applied in a blanket, everyone gets the same treatment kind of way, which is how most treatments are evaluated. So there is an enormous amount of money being wasted on doing these simple RCTs, randomized controlled trials, to evaluate single interventions that are applied generically to everybody. There are lots of different types of intervention for back pain. There's exercise, there's education programs, education about what pain is, education about managing pain, those kinds of things. There's pharmacological management, there are social interventions, there are psychological treatments, such as cognitive behavioral management, mindfulness therapies, things like that. And there are a small number of people for whom specific treatments like surgeries or injection treatments might be effective. So there are lots of treatments available. The problem is we're not very good at deciding who should get what. And there's a large probability that if we can more appropriately select the treatments for and target them to the right people at the right time, we might have a better effect. This problem is so bad that we can only provide a definitive diagnosis for less than 10% of people, and everybody else is called non-specific low back pain. And within that, there is no clear way or direction to how we might then personalize care. So maybe we could improve the outcomes if we used a system that enabled us to use artificial intelligence to aid the assessment and guide treatment selection. Now, the issue is that all pain, but particularly back pain, is multifactorial. There are biological, psychological, and social factors that all interact to influence a person's presentation. So there may be one person who has a sensitized nervous system where they're hyper responsive to different sensory inputs. There are other people who have problems with work support. There are other people who've got psychological factors that expose them to greater risk of experiencing injuries. So low self-efficacy, things like that. So there are many different factors that are relevant. And in fact, we've just done, over the last couple of years, published a series of papers that used an approach that enabled us to identify, using fuzzy cognitive maps and collaborative modeling, to identify what does the community believe are all of the factors that might be relevant for a person with low back pain and influence their symptoms, their quality of life, and their disability. And you're not really supposed to see all the little tiny words. The message is supposed to be that there are so many interacting factors. How can a mere mortal be able to integrate that information and make relevant decisions about what treatments might be most appropriate for a person at a particular time? So clearly we need to have detailed investigations that give us information about multiple domains, but then we need to have resources that enable us to be able to integrate that information and make clever decisions. And clearly there's a role for artificial intelligence in doing that. So what I want to do just very briefly is give you a taste of some of the insights that we have about the types of factors that might be relevant for a person's back pain, and talk about some of the key issues about how it's relevant and why. So what I'm showing you here is a person's pain, and traditionally what people have thought about is back pain or any musculoskeletal pain is either acute, subacute, or chronic, based on how long the person's had their pain for. And when we look at risk factors, so factors associated with low back pain, a lot of research has tried to identify what are the factors that would cause a person to have an acute episode. And most of those things are biomechanical. So lifting in a twisted position, or lifting when you're fatigued, or doing something mechanically or physically strenuous that is beyond the tolerance of the tissue. So most people would argue that their first episode of back pain happens because of some biomechanical mechanism. And there's good evidence of biomechanical risk factors for that. That's great. And maybe we can prevent people from getting that by providing them with guidance about how to use their bodies in work environments and things. But 80 to 90% of us have already got it. So it's not about stopping it the first time. It's actually about trying to improve its recovery and prevent it recurring. So because of that model of considering back pain as being either acute, subacute, or chronic, a lot of work has then looked, well, what is it that happens at baseline that predicts someone going on to becoming chronic in the long term? So maybe we can nip that in the bud. Maybe we can intervene and influence that. And a lot of those factors have been found to be work-related factors. So a person who injures themselves, who then doesn't have a supportive superior in their job, who enables them to undertake modified activities or whatever, those people are more likely to have a bad outcome and develop chronic pain. There is other evidence related to healthcare systems. So healthcare systems that enable people to not have to work, it can sometimes reinforce the development of persistent pain symptoms. And there's a really famous study from San Francisco with a fireman when if you're a fireman and you injured your back, you got great workers' compensation. When they took that away, no one got chronic back pain. They had acute episodes, but they got better. So there was a change because of the social support structure that influenced their management. So social factors are really important. There's also some evidence of biological factors, and I want to tell you a little bit of story around this because it leads us to another one of the complexities that reinforces the need for artificial intelligence. We've done a whole series of studies looking again at factors that might present at baseline that influence a person's long-term outcome. And some of these things relate to pain sensitivity. Some of these things relate to inflammatory or immune system responses in the body. So we've done an experiment where we've taken people who've experienced an episode of low back pain. We make a whole range of measurements using questionnaires. We take blood samples, we measure their pain sensitivity in their back, but also other parts of their body. And then from the blood, we make measures of their the immune factors. We make measures in questionnaires related to psychological factors, their sleep behavior, and a whole range of different features. We then follow these people for a year. I'm going to show you some of the data from 6 months. And then we make recordings of people. We get people to report their pain and disability every 2 weeks over that period. What we've then got is we have a group of controls. We have a group of back pain patients who've been part of this. And then those people are allocated to be either recovered. So they are people who no longer have back pain at 6 months and have maintained that for some period of time. There's partially recovered whose pain's gone down, but it's not quite better, or it's variable. And then there's people who really haven't recovered. And we try to identify what factors at baseline might predict the long-term outcome. So CRP, C-reactive protein, it's a marker from people's blood that tells you about kind of the overall immune response. So it's a marker of immune system activity. And what we see is that in the acute case, so in that early period when we take the blood sample in the first case, these people have got elevated CRP, and that makes sense. So if you've got an injury, then it makes sense to have an immune response. So that's what we'd expect. But when we look at the outcome at 6 months, we see some actually really quite interesting things. So what I'm showing you here is a heat map that shows each column is a separate participant. Every row is a different factor. So CRP, TNF, interleukin-1 beta, interleukin-6, they're all inflammatory markers. And then pain intensity, there's a series of psychological features, and then sleep quality. Now, the way I've shown this is that blue means that feature is not expressed very much. Orange means that it's expressed a lot. So what you can see is this group here have high expression of this general marker of the immune response in the early period. Now, what I've done is a cluster analysis where we've tried to identify groups of features that fit together. And then we've looked at the outcomes for those clusters. And what we find is this cluster 1, so these people who have an early general immune response, they're the group that has 59% who are recovered. So they're either recovered or partially recovered. A 59% reduction of their pain intensity on average, and more than half of them are completely recovered. Some are partially recovered. So what we see is this group has a good outcome. So they have an inflammatory response, they have a good outcome. There's another cluster who have a terrible outcome. They only have a 17% reduction of pain overall. And most of the people who are unrecovered are in this group. There is very few people who are fully recovered. Now, these people have a different profile. They have an elevated immune response, but this is particularly involving tumor necrosis factor, which is a marker that is associated with many problematic inflammatory conditions like arthritis and other conditions where this is one of the markers of the severity of the condition and has been associated with chronic pain. These people are also high in terms of depression, and they also have negative aspects of their sleep quality. So what this suggests is that if you have an inflammatory response, it's not necessarily bad, but it depends what kind of inflammatory response you have. And if you have an early inflammatory response involving TNF, and you're also depressed, and you're also sleeping badly, then your chances of having a bad outcome are very high. So the important message I get from this is that no matter what we look at in terms of biology, psychological, and social factors, it's the interaction between them that is really important. Because you can have this high response, you can have depression, but unless it's together, it doesn't have a bad outcome. So it is about the interaction, and that's what is going to exceed the human capacity to be able to integrate these multiple pieces of information together. There's also another group. This is the group who is most sensitive at the start. So you poke on them and they get the most pain. They actually do really well. So it's not about how sensitive you are at the start. It's about this combination of factors that work together. The same thing relates to when we look at the sensitivity in more detail. This is showing the pain thresholds to pressure, heat, and cold stimuli. And basically people with back pain, so the grey ones, they are more sensitive. So the pressure that you poke on their back is less when it becomes painful. So they're more sensitive to pressure. They're more sensitive to heat, and they find cold becomes painful at a higher temperature. So they're more sensitive. So very sensitive. And the people with the worst pain are the ones who are the most sensitive. But again, it's not just those features alone. So here's another heat map. Here are 3 clusters again, this time clustered based on the sensitivity data. It's a little bit complicated to interpret because blue means lower score, which means if pressure is lower when it's painful, you're more sensitive. So blue in pressure means more sensitive, and blue in cold means more sensitive, but red in heat means more sensitive. So what we have is this group who are more sensitive. Alone, those factors don't necessarily matter, but when it's combined with high psychological features, again, it's a problem. So it's a combination of factors that are relevant for the person's outlook in their pain condition. So what I've suggested is then that there is this combination of factors that are relevant for a person's outcome. And what I've shown you there is what happens in the early period that might predict whether someone has a long-term negative outcome. And that means that maybe if we intervene on those factors, maybe if we use some antidepressive interventions or treatments to reduce their tumor necrosis factor, and improve their sleep, maybe we can have an impact on changing their long-term outcome. But and again, it's the interaction between factors that's important. But what I'd like to suggest is that's actually not most people with back pain. And there is new data that's really starting to reconceptualize how we think about this condition, which I think means that we need to reframe how we consider the management of back pain. And that is that back pain is not just ongoing pain or separate acute episodes. It's, for most people, a condition which is ongoing and characterized by periods of when they're worse and when they're better. So there are some people who may get almost better and stay better, but most people will have these recurring episodes. It may go down below the threshold where they experience pain, or it may always be just hanging a little bit above it. And there's now some research qualitative research from back pain patients that says that people with back pain consider themselves to be a back pain patient even when they don't have pain. So like someone who has arthritis who thinks I've got arthritis even when it's not flared up. So back pain is the same. So this opens up a whole lot of other opportunities, because what that means is that maybe we're not just trying to prevent someone transitioning to chronicity. Maybe what we actually want to find is maybe there's factors that in the short term, transient exposure to individual features might be relevant for someone experiencing a worsening of their condition. So rather than just trying to prevent it in the long term, there may be things that we can target in the short term that actually make this trajectory smoother, get rid of some of these flares. So maybe we have to reconceptualize how we look at the condition. And what that means is maybe our approach needs to consider, well, what are some of the factors where transient exposure might increase a person's probability of having a flare? And again, we're going to need to think about combining multiple sources of information together to be able to make that decision of which ones might be relevant for that person. For example, it may be that an episode of poor psychological health. So maybe someone has an increase in their depressive mood for a couple of days. And maybe if you combine that with being fatigued and lifting a heavy box, that might be the bad combination for you. But otherwise, lifting a heavy box might not be a problem, or being depressed might not be a problem. So it is probably a combination, again, that's relevant. So we've done a whole series of studies now trying to understand what are the factors that might independently or together be relevant for the flaring of symptoms. And I think this is really important because there's lots of factors that have been thrown out because they don't cause someone to get a new episode. For example, someone might be fearful that a particular task might be problematic for their back. That's unlikely to make them have a new episode of back pain, but it may be enough to cause them to have worsening symptoms for the next day. So there's a whole lot of features that may have been thrown out. Another thing is weather. We know that everyone who has arthritis thinks that their joint pain gets worse when the weather gets bad or when it rains. And one of the issues is that that's probably not enough to cause someone to get a new episode of their condition, but it might be enough to cause a subtle fluctuation. So there's a whole lot of things that may have actually been thrown out because the arthritis data suggests that weather is not important. It doesn't make a difference, but I suspect they may have measured the wrong thing. So maybe we need to take this different view. So maybe things that there may be a whole different set of potential risk factors for this type for transient flares of the condition. So transient exposure to a whole range of different factors might cause this, and it might be the interaction, psychological, social, behavioral, biomechanical, whatever. There's a couple of really interesting ones, and that is sleep and physical activity. And sleep is really interesting because up until recently, we've always thought about sleep as being interfered by pain. So if someone has pain, it interferes with their sleep, and that's bad for many aspects of your body health. But what's been shown recently is that maybe it goes the other way as well. So maybe if you have a night of bad sleep, maybe that increases your risk of having a flare of back pain. So, same thing with physical activity. We often think of high physical demand being bad, but clinical trials show that if you rest too long with back pain, you're more likely to have a bad outcome. So is it too much activity or too little activity that's bad? Or is it both, depending on the context? So we need to understand the detail of the relationship to flare. So we've done a whole series of studies trying to understand what are the risk factors for flare to identify some potential targets that we might want to consider in interventions. So we've used this case crossover design where everybody is their own control. So they have data recorded for a period, and then there are some periods when they don't have a flare. There are some periods when they do have a flare, and we compare features that are present before periods with and without a flare to see what are the things that are different that might be the risk factors or the causal mediators of their flare. So we do this, so people wear simple sensors, active pulse sensors for 28 days, and then they provide input data into a program, an app that they have on their phone where they're prompted to provide responses every day, several times. So the study I'll talk about now, 126 people, they've had back pain for at least 3 months. And these are people who self-identify as having pain that is variable. Sometimes, some days good, some days are bad, which is most people with back pain. And then they have these 2 different data measurement devices. The questions we ask are around a whole range of different things. So we ask them about their sleep quality and the duration. We ask them about their pain. We ask them about whether they believe they've had a flare, and we've developed a definition for back pain patients with patients to identify that. We measure psychological features, self-reported physical activity, which we can then relate to the objectively recorded physical activity, self-reported fatigue, disability, work issues, medication, and treatments. So the way we analyze it, because it's a case crossover design, what we have is we find the periods when they have a flare. So if we look at the pain reports every day, if their pain is more than 2 points above the mean pain they have for the period, we define that as a flare based on pain, so a pain-defined flare. And then we look at the days before that, so that's the period preceding a flare. We also have self-reported flare. So someone says they have a flare. So their pain may not actually be above the average, but they may believe that they've had a flare. And that's what we've found in our qualitative work, is that patients, it's not just about the intensity of pain. They might have a continuous amount of pain, but other things have meant that it's now more problematic for them today. So we have self-reported flares, or flares defined by pain. And then we have periods when they didn't report a flare and their pain was just at its average level. So we look at the 3 days before that as well, and we compare these periods preceding the flare or no flare. So we've done analyses looking at 1, 2, and 3 days before the onset of the flare, and we use conditional logistic regression to look at the associations between these factors. So this is the self-reported pain, psychology, and treatment data. And what you can see is that in terms of pain, people who have a pain-defined flare, so a day where the pain is worse, they actually had more pain the day before. So maybe this is simply a gradual increase of their pain intensity. People have a self-reported flare. It's only if they report pain that morning that it's related. So a self-reported flare is not just about this gradual accumulation, it's a more spontaneous thing. Fatigue is relevant as well. People who have had a day when they said they felt fatigued, the next day they're more likely to have more pain. And people who have this measure of perceived self-efficacy at work is greater in people who, but it's 3 days away. So I'm not sure whether that's just a quirk. It may not, it is probably not relevant because it's being a meaningful finding. But if we look at the physical activity data and the sleep data, we see some other really interesting things. And let's look at self-reported flare first. So people who said they've had a flare, if they report that they've had a night of good quality sleep, they're less likely to have a flare. If they report that they slept not as good as they could have and quite badly, then they are more likely to have a flare. And if we look at the pain-defined flare, we see similar things, just a slightly less strong relationship. And then if we look at the activity monitor data, we can see that people who have a day of low physical activity are more likely to have a flare. And that's if we measure it through the sedentary time or through calculating their metabolic equivalence. And people who stand more or have slightly more physical activity are less likely to have a flare. And the in-bed hours in terms of pain is not significant. So that would tell me that it's the quality and not the quantity of their sleep that's important, because all of the subjective measures of quality were strongly significant. The measures of just what time they went to bed and got up isn't. So quality, not quantity. So I think this is what this is telling us very beautifully, is that there are a range of factors that vary that can give us some insight into what might be mediating the onset of a subsequent flare. So it's starting to give us some idea about what we might want to look at. Posture is something that has always been talked about as being relevant for potentially causing pain, and maybe it is a cause of flare as well. One of the challenges is that there's a huge social media purge at the moment saying that posture is not important, that posture is a myth, and posture has nothing to do with pain. And unfortunately, I believe that this is because we haven't tested it in the right way, because people make single measures in a single session in a clinic or in a laboratory, usually using an X-ray where a person knows they're being monitored. So you get a measure of their posture. You then expect that everybody has the same difference. And what this study shows from some really nice work done by Peter O'Sullivan's group is that there are two different, if you look at controls, they have this particular profile. If you look at back pain patients together, they have the same profile of different angles of their spine. But if you separate the pain group into two different subgroups, they're very different from control. So it's not that everyone changes their posture in the same way. There's individual variation that is probably relevant. And the other thing is we don't consider exposure, in that if you have a particular thing that you do that is high load, such as lifting in a bad posture, but lifting 200 kilos in a bad posture, you only have to do it once for it to be a problem. But if you're lifting, if it's a different task, so sitting with a slightly problematic posture, you have to do it a lot for it to be a problem. So there's this need to consider not just what they've done, but the relationship between the load and the exposure and the potential for tissues to tolerate that. So those three factors have been missed. So I actually don't think that we've asked the right question yet, and that is we haven't really measured how people use their body in the real world. We've failed to consider individual variation, and we've failed to consider how people live their lives, and maybe that's relevant. So I think we need to try something different. And one of the next phases of our FLAIR work is about looking at whether features of the way a person uses their body in the real world measured with wearable sensors is associated with their outcome, with the flaring of their condition. So what I hope I've suggested so far is that I think we're starting to build a picture of the factors that might be relevant for different groups of people. This big bulk of people with these transient flaring of their condition, it's a complex phenomenon. There's multiple factors involved, and whichever way we look at it, the interaction between variables is critical. So where are we going wrong? So our current model of back pain care in Australia is very straightforward, and that is a person will attend their chosen healthcare provider, might be a GP, physiotherapist, chiropractor, whoever. That clinician will undertake a limited assessment. They'll do some assessments that might be bend over, touch your toes, did that hurt? No, it didn't, whatever. They might ask some questions, might do some questionnaires, and they'll build up a picture of what this person is, what they think is relevant for the person. And then from their very narrow battery of treatments, they'll select some options, and then they'll send the person away with that. They'll come back. If it didn't work, they'll try something else. If it did work, they'll keep doing the same thing. So clearly there's a few problems. For example, the assessments are really limited in their scope, and most of them aren't really going to reflect what's happening for the person in their life in the real world. The treatments are really limited. They're not really guided by what they've assessed. The assessments are really more about an outcome measure of being able to determine whether someone's getting better, rather than a measure that will help choose what treatment someone should get. So it's a lot of treatment is really applied in a really blind manner, very generally applied, maybe a bit of tailoring to dose or something like that. And then there's really poor treatment adherence and really limited follow-up. And often what happens is that people will not improve, so they won't come back, so you won't know. And it's a disaster. Our healthcare system is not working. So what we're thinking of is a new model of care that is as aided by wearable sensors and AI. And just as a really simple overview from the outset, I think wearable sensors give us an opportunity to do better assessment, to be able to identify potential targets, understanding how people are using their body and how they're sleeping, how their physical activity is, how their mood is changing with some input devices. So getting an idea about what it is that might be relevant for that individual that can help us with our treatment decisions. Then wearable sensors aiding with treatment support. So using wearable sensors to provide people with feedback, such as giving them feedback about the quality of the sleep they had the night before and what might they try to modify that the next night. Did they go to bed too late? Did they use their mobile phone for immediately before they went to bed? Those kinds of bits of feedback. Or physical activity, giving people a graduated program of being able to gradually pace themselves back into normal physical activity levels. And then monitoring, so that the healthcare provider would be able to receive information about the progress of the patient and their adherence to treatment programs. So wearable sensors have a big piece of what we might be able to do to change the system. And then AI is, as I keep highlighting, I think the decisions that we need to make in this complex system of back pain are too complicated. There are too many factors to integrate together to be able to understand, well, what might be the best treatment for a particular individual. Because it may not be the thing that is most obvious. It may be that there are other features that supersede the most obvious changes, depending on what it is that's a combination for that individual. And if someone is presenting with sleep, depression, and immune response, do you want to do all of those things, or do you want to target their sleep first, or do you want to target their depression? There's a whole range of decision support guidance that is necessary. And then also, if we're going to be using this complex data, having automated methods to be able to extract the meaningful features from those data are going to be really important. So using some AI and machine learning approaches to support that as well is going to be helpful. So the way I see the system working is that there'll be this whole system of user input and wearable sensors that can provide us with real life information about how a person is using is living their life. That will be automatically analysed to extract features that we believe are relevant to assist with the decision making. That will be combined with other data that we might generate from our consultation, such as clinical features of their pain, other things like that it might be that we do genomic analyses, and that might also help us decide what treatments are necessary. We interrogate that data and provide some support for the to the most effective, the predicted most likely interventions. They are then guided to digital health resources that support them in undertaking that management, because a lot of the things that we need to do with back pain are self-management approaches that supported self-management, such as exercise, weight loss, sleep improvement, all those kinds of things. And then wearable sensors to track the progress so that they can alert the clinician that, well, maybe the person's not adhering to their program, or maybe they're deteriorating, maybe they've stopped progressing, whatever. So some information about that can help guide the intervention. And all of that is put into this a database that includes the initial presentation, and assessment findings, the treatments that were selected and the outcome, and uses that in this perpetual way to build precision of the decision support system. So over time, refining this decision process. So where I see that AI fits in is pretty much everywhere. And that is, clearly there's some potential role for supporting the classification and extraction algorithms that we need for analysing these different types of data that we have available. Of course, the decision support, so integrating the data and interrogating it for information about what might be the appropriate treatments to provide. Analysis again to help with some of the feedback that these devices may provide. Automatic data analysis and extraction for the data that then needs to be fed back to the system and to the clinicians, and then ultimately this this perpetual development and refinement of the decision-making support. So I see this fitting into a healthcare system, something like this, where a person has a low back pain episode. They are guided to download an application that houses the front end of this program. They may do that themselves, or their healthcare provider may do that. They then answer some questions that identify the risks that they have of a bad outcome. So one of the ideas is that if 80% of the population are getting back pain, not everyone needs intensive treatment. Some people will do well regardless of what you give them. So maybe we can find the people who can have a more light touch approach and the people who need a more intensive intervention. And that may be a way that we can refine our allocation of healthcare resources. So some questions about how intensive this should be. Some simple questions that give some guidance about some of the initial aspects that might guide the treatment. And then the low risk people might get a self-management program where they're really just supported by an app, and maybe they can input some data from their wearable sensors on their iPhone, whatever. So a low key type of intervention. But those who've got more intensive, moderate to high risk, those people we may refer to collaborate with the healthcare provider to undertake this management in a more refined manner, to be given a set of sensors or advised to incorporate the data from a set of wearable sensors, and then be put into this cycle of detailed assessment, automated analysis, decision support, blah, 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 and hopefully have a good outcome. And those who are in the low risk group, if they have a bad outcome, they can then swap over into this mechanism and have the more detailed support. So what can we measure? What could we measure? How should we measure it? What data should we extract? How should we use the data? And does it make a difference if we do? And I just have a couple of slides about each of those. There's lots of things we can already measure that are available to everybody on the planet if they have a smartphone. Things like accelerometers and GPS for being able to measure physical activity. Body posture, there's simple measures that you can make from accelerometers and gyroscopes. Sleep time, every device has Garmin watches, Fitbits, all give you some feedback about how well you slept based on how much you moved your arm when you were sleeping. Might not be the most accurate way to measure sleep, but maybe it gives some useful information that's meaningful. Psychological factors, people can life log. They can put in some data on their phone, and social media, social interaction they can log as well. So what we've done already is to identify where are sensors already available that we might be able to build this system. So we've been targeting activity, sleep, stress, and posture and movement. And we're in the process of putting together an MRFF application for a new grant that relates to using what we can access already into this kind of program. I have a vision for something far more exciting than this, but this is where we could start because this is what's currently potentially available, where we have the devices and we have programs that can be used to manage those domains. What could we measure? Well, there's lots of work being done of actually more accurately identifying sleep parameters. So using, and Focus Band, Brisbane company that's developing these simple devices that can give us some information about a person's EEG, from which you can generate measures of sleep quality, of different phases of sleep, which is a more objective measure of sleep quality. We could also measure during the day things like attention and fatigue. So there's some other opportunities because it's what it's providing. There's sensors that might be able to provide us with measures of things like cortisol and lactate. So giving us information about stress, giving objective measures related to stress, measures related to fatigue. So things that we might be objectively able to measure that can assist in providing greater quality. There's people working on lots of social measures. So listening in on people's phone calls in an anonymized way to be able to understand how much interaction people are having socially, using GPS to work out where they're going. Are they staying in the home all the time? Are they going to work? So making some objective measures of some social behaviors, obviously with privacy issues and all of that taken into account. So there's a whole range of other parameters that could be integrated into this world if once the technologies become more readily available. How should we measure it? Clearly, we need to do some work to try and make sure that these devices are lightweight, unobtrusive, ideally wear and forget. It's put on and you don't have to think about it after that. A long battery life and easy to recharge, those kinds of things. So lots of practical considerations, and there's lots of work being done in many places around the world to make really clever electrodes that are like tattoos, and energy systems that use things like movement, heat, solar inputs. So a whole range of different ways that we might be able to simplify some of the charging. And then a lot of work being done looking at automated ways to classify and analyze the data. So there's lots of work being done on those things, and that's an important target of what we should be doing. How should we use the data? Obviously, automated decisions is going to be a really support is going to be a really helpful thing for clinicians to decide what to do. Giving feedback to patients is really going to be a game changer for making sure for assisting patients to change their behaviours, and feedback to the clinicians to early identify lack of progress or poor adherence is really going to help clinicians be more effective in ensuring patients are improving their outcomes. And then, of course, feeding into this ever-developing decision support tool with greater precision over time. Do we think this will make a difference? I hope so. It's paradigm shifting in the way that we consider the care of musculoskeletal pain. But of course, one of the things we're going to have to do is test it. And our MRFF grant has to include an evaluation component to test whether, even when we apply this model in a simple way, does it actually lead to some clinical improvements? So what I've tried to do in this talk is to give you an overview about where I think AI can fit. And AI is not something I have expertise in. I have expertise in the condition and understanding how to treat it and the potential role of these different technologies. But what I need is collaborators, and obviously Alejandro is providing us with great support as part of our MRFF team for the putting together this new model of care. But clearly there's many ways that AI could contribute our vision of how we might change the management of back pain. And then I just wanted to finish then just by acknowledging there's a lot of people involved in the work that we've been doing, and a lot of the funding has come from NHMRC over the recent years through some big grants to help us get the initial pieces done. I just threw this in. We're also interested in using AI in other ways. For example, this is showing you the back muscles in people with back pain. And one of the fundamental things you can see is that as back pain progresses, there are changes in the structure of muscle, and we're working on automated ways to do some image analysis of those kinds of features as well. So there's other ways, and this is another potential marker that could be used to guide the selection of treatment. This person may need a treatment that's very different from this person because the availability of contractile muscle is much less. And then just finish just by acknowledging the contribution of the people I've been working recently to put together this structure of an MRFF grant to try and get some funding to support the initial development of this integrated system. So I'll finish there and very happy to have some discussion.
Perfect. Thank you, Paul, for your great talk. We already have some questions in the forum. There's one from Sri Krishna Bhatt. He's actually asking more about if you can elaborate on predictive models. So he's asking whether you could simulate lower back pain and whether this can be helping for both predicting and perhaps helping creating simulated trainers.
So I guess my first thought about that is I'm not sure that we yet know enough because of the complexity of interaction of so many factors. The challenge for simulating the development of back pain is that it depends on understanding how things fit together. And I suspect there could be some simplistic models developed based on some predictions that we already have, such as, well, when is it that the combination of depression and psychology and sleep and immune system function might be problematic. But the problem is we don't really know how all of the other 3,000 things combine to influence that. So I think that we might be able to make simple models, but they may not necessarily be accurate yet because of the missing data to build the complex interactions that are relevant.
I have a question also in that direction. So like with the data that you already have you looked into how well in advance you can predict a flare? Like if you look,
So the only thing we've done for that is we've looked 1, 2, and 3 days in advance. And I guess my feeling is that the further away it is from the actual flare, the harder it is to defend that it's actually relevant, particularly if the intervening days are also not impacted by that factor. So I mentioned that there was one issue of self-efficacy at work and it was only relevant 3 days in advance, but the 2 days preceding, it wasn't a problem, which makes me suspect that it probably was a furphy. It was a not real finding. And I guess my feeling for flare is that it really is transient recent exposures that are relevant. In terms of the long-term outcome, so predicting the transition to chronicity, I think that is something that we can do much more in advance. And in fact, we've just published a paper that shows that if you evaluate someone in the first week after their back pain, you can make a bit of a prediction about where they're going to be in a year. But if you do an evaluation 12 weeks later, you can be really precise. And obviously it kind of is a bit of a no-brainer in that the more, if they've had their pain for that long, they're probably going to have a bad outcome. But in terms of the specific psychological features they present with, we can be really more precise about what predicting the bad outcome. So I think for that type of thing, we can be predictive very early. But for flare, I really do think it is a transient exposure that is going to be impactful very soon afterwards. And I think that's what flare is about, is when the planets come into alignment, that you do this combination of things, it is going to be very soon after that's provoked a problem rather than days or weeks later. But I think there could be undercurrent features that for example, with the omics world. So there is potentially metabolomic factors that tell us something about what is actually being, how your DNA is actually programming the response of your body to a particular context. I suspect there may be features of that set you up to be more likely to have a flare. So it might be that people who've got an elevated whatever factor, they may only need a little tiny tweak of the poor sleep or something else. So we might be able to identify other factors that make you more sensitive to flare, but not necessarily the factors that cause the flare. Yeah.
I see two also questions regarding once you understand those predictions models and you want to intervene. And the questions go into how these such predictions can affect gender or racial biases. And there's another question about what can happen if you give false advice to patients. So if you could elaborate on those ethical questions a little bit.
So in terms of gender and racial biases, that is a really important factor. And we know, for example, we know that there are features of the physiology of the pain system which are different in men and women, and some of the neurotransmitters that are used. For example, glutamate. So if you eat Chinese and you increase the glutamate in your blood, it has an impact on sensitivity in women, but not men. So there are specific differences, and there is greater potential for central sensitization in women. So there will be factors that are gender specific that need to be fed into these models. And there is likely to be racial factors as well. And there's one of the things that we've just applied for an NIH grant resubmission. And the first submission, one of the things that we had to address in more detail in the resubmission was how we were going to ensure that we included sufficient people that were racially diverse in order to address that question. So I absolutely take on board what you're saying, and that will have to be part of it. The ethical question about is there an issue if we give the wrong treatment? If the wrong sorry, was the question about if you provide the wrong
if you give false advice to patients?
I'm
guessing in terms of trust in AI and whether you would trust your results.
Yeah, I suspect for the majority of the treatments that we're considering that are in this domain, they are conservative interventions that are low risk and potentially beneficial, that have no irreversible side effects. So if, for example, we allocated someone to receive an exercise intervention and it didn't help, it's not really caused them harm. There are certainly things, for example, surgery. You don't want to be inappropriately referring a person to have surgery when they don't need it because it's irreversible. So there are ethical decisions, but for the majority of the interventions that we would be considering, in fact, this is probably a great condition to deal with because the risks for the treatments are much less than, for example, using AI to select breast cancer treatment and choosing the wrong drug and then not treating someone early enough. So I think this is ethically an easier domain because the risk cost of the interventions is less. So I think back pain's a great thing for us to be investing time. Challenging in using this model because I think it can be a good test bed to see whether it can work without some of those other high cost risks.
There's a question from Shakes, whether you have tried to image pain using MRI, fMRI, CT, and whether you have looked into mapping functional changes to pain as an indirect measure.
So Shakes, great question, and it is an international endeavor to find the imaging marker of pain, and so we have a collaborator in some of the flares work that we're doing, Luke Henderson, who's an fMRI expert. So we're including that in our domain. The problem is that there's some promising things that have been identified. The challenge is that pain is not, it's not something that has one area. You don't have a pain center in your brain. You have this interaction between multiple regions of your brain that is individual. And so Ron Melzack called it the pain neuromatrix. And basically there's every part of your brain is involved. The part of your brain that's involved in somatic sensation from your body, the part of your brain that's involved in emotion, the part of your brain that's involved in cognitive reasoning, your fear center. So a whole range of different parts of your brain are involved. And people identify particular markers they think might be relevant, but then generally the next study shows it's not relevant. But there are some features related to there's been some work done looking at functional anisotropy of particular pathways that seem to be relevant for some pain conditions, and there's also work being done looking at structural change. So looking at reduction of grey matter volume in certain areas of the brain seem to be relevant. So I think there's something in there, but it's never going to be a universal marker. It's going to again be this combination, like you may have some features in specific presentations, but not in others.
Good, thanks. I'm going to consolidate questions from 3 people, from Nadine Foster, Camila Shirota, and Anton van der Vecht. So Nadine says, a key challenge will be the large datasets needed. With these deep phenotyping data measure and all, how to overcome this? So you will probably need thousands of patients to develop, train, and refine AI models. So what are your thoughts on how to build a more generic personalized data capture vehicle that you can leverage from multiple research projects you could gather data from? How you can connect with other clinical research teams that have similarly trying to capture data from different people, and what are your thoughts on that process?
As Nadine knows, we're looking at identifying ways that we can build this over time. And so, for example, there are some really clever clinical trials designs that enable adaptive decisions to be made, where you can start with straightforward decisions and build the complexity over time. And you can build steps into the model that enable you to implement more challenging decision options, but you start with a simple model that's feasible, and then you build it over time. And I guess what I would like to see is that we have some a priori defined decisions that can be feasibly investigated, and then over time we can build in some complexity that allows us to become more refined in our decision-making process. And hopefully there are some advances in trial design that enable us to do that. Yeah. And in terms of connecting with other data sources, I think that's a really great idea. And there's a question here about, well, a lot of these measures are relevant for other conditions, and that's absolutely true. And if we, for example, something like the UK data biobank, it provides a huge amount of data. What it doesn't provide is the fine detail of how people's back pain is changing. But maybe we can have similar resources that just add a couple of extra measures where we can actually have data that's of utility for a host of different conditions. For example, stress, it's going to be relevant not just for someone's pain experience, but it's also going to be relevant for their cardiovascular health and other things. So I see huge advantage for this being, to be able to create a resource that is interrogatable for a range of different conditions that a person presents with, because most people with back pain have other things, particularly when we consider that 90% of the population have it. Of course, there's all of these other conditions that are going to be involved as well.
Given those multiple factors, do you have an idea of roughly how much data you might need in order to get accurate or predictions or results? Like, are you talking about thousands of patients wearing sensors and getting all these factors?
So the number of people that are required depends on the size of difference you expect to have, the number of factors that you hope to have in the decision-making tree, and the number of treatments that you have available to provide. And one of the things we're actually working on at the moment is working out how the plan is to go in with the ultimate, but then to evaluate the feasibility and to consider how do we need to tweak the initial design to make it feasible within the population size that we can recruit, and then build from that.
Great. Looking into like a little bit more on the usability aspects of trying to gather this data, what's your experience in trying to, what is the willingness of people on being constantly monitored and interviewed for you to be able to generate?
Sure. And so one of the critical aspects that needs to be part of a project like this is to actually work with the people who will be using it, and it's both the clinicians and the people who are receiving the care. And so the thing we need to make sure is that we optimize the system to maximize the feasibility. And that's what when I was talking about the optimizing the design of the sensors and things like that. I think we do need to do a bit of work to work out how can we design these sensors to be as easy to use as possible. And we're going to need to co-design with patients to understand what it is that is appropriate. When we do research, we're able to get people to wear, in hot, sweaty Brisbane summer, to have 2 sensors, one on their thigh and one on their trunk, 126 people for a month continuously. So people do it, but whether they would do it as part of their management, I think they will, but we need to work out how to make that, how to increase the probability that will be successful. And I think that is partly about the design of the sensors and the systems that we integrate that into. And for example, we've been meeting with physiotherapists to work out, well, how would they like the data to appear, and what would be ways that they may or may not integrate with the system? What are some of the barriers and facilitators? So it's to optimize the usability is a critical part of the program that we need to do.
Thank you, Paul. I think this is a great, very insightful talk, and definitely lots of opportunities for everyone attending to this webinar and try to collaborate together towards this vision. In the interest of time, I think we should leave it there. I thank you for your time, and thank you all the participants for attending this webinar. All right. Thank you very much.
Thank you very much.